We will get started in just a moment. Good morning, everyone. Hello and welcome to you all. I'm Dr. Alexis Briggy, Director of Psychology at Silver Hill Hospital, and we're delighted to have you join us today where we're privileged to welcome Dr. Ryan Herringa presenting on the topic of pediatric post-traumatic stress disorder, diagnosis, treatment, and neurobiology. I will have the pleasure of introducing him in just a moment. Some quick housekeeping to start. Our next grand rounds is going to take place on April 23rd with Dr. Stephen Martyr, who will talk to us on the topic of new pharmacotherapy for psychosis. And to see all of our Silver Hill Share events, visit silverhillhospital.org/calendar. Back to today's lecture. Your questions remain an important part of our grand rounds. I'll moderate a Q&A discussion with Dr. Herringa at the end of his lecture. And this is a great opportunity to put forward any questions and comments, which you can submit at any time during the lecture by using the Q&A link. So please use the Q&A link for any questions. And if you would like CME or CEU credits today, please complete the evaluation survey that will automatically show up in your browser when we end the webinar. A link to the survey will also be emailed to all participants tomorrow. And please note that this email will be a Zoom email coming from Silver Hill Hospital events. The email will also contain a link to the recording and a slide presentation. Please keep your eye out for it. So that all participants have enough time to complete the survey, it's going to remain open till the end of the day on Friday, and certificates will then be emailed within the week. Any questions, please send an email to shhevents@silverhillhospital.org. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. Dr. Herringa will show a slide with his disclosures, and it is now my great pleasure and honor to introduce our guest speaker today, Dr. Ryan Herringa. Ryan Herringa, MD, PhD, is the director of the Division of Child and Adolescent Psychiatry and the UW Health Professor in Child and Adolescent Psychiatry at the University of Wisconsin School of Medicine and Public Health. He is a pediatric psychiatrist and neuroscientist whose work explores the neural substrates of childhood traumatic stress and PTSD. He directs the BRAVE Research Collaborative, which stands for Building Resilience to Adversity and Violent Experiences, which seeks to map neurodevelopmental trajectories following childhood trauma. Specifically, BRAVE uses structural and functional neuroimaging combined with behavioral, physiological, and genetic approaches to develop biomarkers of vulnerability, recovery, and resilience to childhood trauma. Dr. Herringa serves as the principal or co-investigator on several NIH-funded research studies examining neuromechanisms of trauma and PTSD in both youth and adult populations. In addition to his research, Dr. Herringa remains active in clinical care and teaching with specialization in the treatment of youth with trauma-related mental illness. I will now pass the baton over to Dr. Herringa. Dr. Herringa, over to you and welcome.
Thank you so much, Dr. Briggy. It's really a pleasure to be here, and thank you for the invitation to present. It looks like we have a nice showing already of folks in the audience. So I'm going to start with a screen share and see if I can get my presentation up accordingly. All right. And Dr. Briggy, I believe I'll have to switch this again. Can you confirm that you're seeing the right presentation?
That looks perfect. Thank you so much.
Looks good now. Okay, wonderful. All right, well, I will get started. Again, thanks for the invitation. It's wonderful to be here and tell you a bit about our work, both clinically and in terms of some of the research regarding PTSD. And we'll get into some of the learning objectives shortly. As Dr. Briggy mentioned, I have served as a consultant with Jazz Pharmaceuticals, though no consultations lately, but those relationships have been mitigated for the purposes of this talk. So what are our objectives for today in terms of the educational objectives? We'll start really the first half of the talk, at least, we'll really be digging into the prevalence presentation as well as current treatment options that we have for pediatric PTSD. And one of the themes that I'm going to try to carry through, both in terms of the epidemiology and presentation of trauma and PTSD in youth, is that there are important neurodevelopmental differences that we need to consider that make both the impacts of trauma and the presentation of PTSD different in kids versus adults. So if you nod off now and don't remember anything else, PTSD in kids is a neurodevelopmental disorder, and there are important differences that we'll get to. So that's one of your take-home points already. We'll then get into some of the neurobiology of pediatric PTSD, at least what we know at this point. And again, I'll try my best to contrast that with what we think or know about adult PTSD, again, with the theme that this is a neurodevelopmental disorder. It isn't simply a little version of adult PTSD. And then finally, in the last few minutes of my talk, I'll dig into some novel biological markers and the hopes of developing new and novel treatments that would actually target some of the neurobiomarkers that we're beginning to unravel. And I'll give you an example of one or two new treatments that we are trying in kids. Okay, so let's maybe start off with the history of pediatric PTSD. Let's put this diagnosis in kids in context before we really go further and deeper into the epidemiology and treatment and so forth. So we published a paper in the American Journal of Psychiatry. This is a review paper about pediatric PTSD. And the lead author was Dr. Russell, shown there. He's a developmental psychologist. Dr. Hain also worked with us on this. And I think Dr. Russell did a really nice job of laying out some of the historical and social context for the diagnosis of PTSD, particularly in kids. How did it emerge? How did it emerge, and how has it evolved over time? And one of the historical pieces he pulls out is the Chowchilla incident. And for those of you probably my age and younger, we were not really necessarily familiar with this growing up. And it was a pivotal point, however, in our understanding of the impacts of trauma and the expression of PTSD in kids. So I'm going to show you in the next slide a short video clip from CNN, in this case, about the Chowchilla incident. For those interested in learning more, there was a recent documentary that was quite well done that's also available. However, I will note the documentary is quite heavy. So for any of you with trauma or family members or friends with a trauma history, there certainly are some sensitive aspects to that. So here we go with the video clip.
Quick warning that some viewers may find parts of this clip disturbing.
We're trying to locate 26 lost children along with their driver.
This is a story that stopped the nation dead in its tracks. July 1976. A bus full of children on their way home from summer school held at gunpoint by three masked men, forced into a trailer and then buried underground. The kidnappers hoping to be paid a huge ransom.
The bus has been found. There are no signs of violence, and there are only horrified guesses as to what may have happened.
Ultimately, after 28 hours, somehow they managed to escape, and authorities were quick to say there was, quote, no indication of harm. That was something child psychiatrist Dr. Lenore Terror did not believe.
The kids were not okay. Somebody got a psychiatrist to come to town, and he made a prediction. He said, one kid in this 26 is going to have a problem. But what happened was that no parent wanted to admit that his kid was the one in 26. By the time I got out there, 100% of those kids were having problems.
Well, there was no diagnosis of post-traumatic stress disorder in 1976. It not only didn't exist for children, it didn't exist for adults either. There was no protocol. There was no way that we knew how to respond after this event at that time.
So this really was a horrifying incident for the nation and certainly for the families involved. And Dr. Lenore Terror is really a hero of mine. I think she was really a critical part of changing our understanding and recognizing very early on the potential impact of an event like this, as horrifying as it was on the kids. Remarkably, they escaped and were reunited with their families, thanks in large part to the heroics of one of the kids who was in the trailer and the bus driver assisting as well. So I'll leave it to you to look more into the documentary or other sources for those who are interested. As you heard, however, children up to that point were thought to be largely resilient to trauma. Why would they have any effects from that? And of course, we know now, in hindsight and with additional study and clinical experience over the years, that of course, children are not 100% resilient to trauma. They will exhibit difficulties and trauma-related symptoms just as adults do, albeit in their own uniquely developmental way. So let's back up a step. You heard in the last part of the clip that PTSD wasn't even a diagnosis when the Chowchilla incident happened. And in fact, if we look at the evolution of PTSD, at least in the DSM, the Diagnostic Statistical Manual for Psychiatry, it wasn't until 1980 with the DSM-3 that PTSD was even established as a diagnosis. And it was technically diagnosable in children and adults. However, there were no recognition of differences between potential expression of PTSD between children and adults at that time. So it wasn't until the DSM-3, the revised version in 1987, that there were at least some symptoms that could be specific or unique to the expression of PTSD in kids, such as repetitive play, developmental regression. And then finally, it wasn't until the DSM-5, this is in 2013, so only 10 years ago plus now, that there was actually a separate diagnostic category for pediatric PTSD, and specifically for PTSD in children under 7. So this is PTSD in preschoolers, and we'll get into the particular diagnostic criteria for that, as well as some of the treatments a little bit later. Now, I'm going to bring up a little quiz slide, and I've sprinkled a few of these throughout the talk. Just to note, feel free to answer these on your own. You don't have to put anything in the chat. There's no audience response system, so just answer in your head, and then I'll highlight the correct answer as we go along. So this first question is, by age 18, how many youth have experienced trauma? So this is a question about the epidemiology of trauma exposure itself in our youth, and specifically focusing youth in the United States here. So the answer is about 2/3, which is when I give this talk to public or general audiences, I should say, people are very surprised at just how common that is. So if you look at the Great Smoky Mountain study, that's primarily where the 2 out of 3 youth statistic comes from. Those data are consistent with other studies as well, but you will see some variation in estimates depending on which cohorts you're looking at. Unfortunately, the lifetime incidence of child abuse, a particularly potent form of childhood trauma, is also quite high. It's thankfully not 2 out of 3, but it's still disturbingly high, such that anywhere from 1 in 4 to 1 in 5 kids will have experienced physical or sexual abuse by the age of 18. So trauma exposure in all ways is really endemic in the United States and elsewhere. However, trauma is not distributed evenly across racial and ethnic backgrounds. So we know, and these are data from childtrends.org, that Black and Hispanic youth in particular tend to have more traumatic events as children, and more than either white or Asian American youth. A group that is not listed here are Native American youth, who, like Black and Hispanic youth, also tend to have more traumatic events over the course of childhood. So there is a disproportionate effect on certain groups. Trauma exposure is also not evenly distributed across age. And I'm showing you data here from the National Comorbidity Survey of Adolescents in detailing the incidence of different trauma type exposure over the course of childhood. On the left is interpersonal violence. On the right are non-interpersonal violence types of events. So to interpersonal and non-interpersonal traumas. And the vertical dotted line, that's age 12, just for your reference point. And what you can hopefully see from these graphs is that for both categories of trauma, the incidence sharply increases in adolescence, really starting around the age of 12 and continuing to rise sharply up until the age of 18. So trauma exposure is certainly more concentrated in adolescence. Now, given all of that, what do we know about childhood trauma and the risk for mental illness? The good news that I will start off with before we talk about specific mental illnesses is that youth are actually quite resilient, and most youth actually will recover from a traumatic event. Obviously, that gets more complicated depending on other factors that we'll talk about shortly in terms of resilience and vulnerability. So, for example, whether you've had multiple traumas or recurrent traumas, what kind of supports you have. For those who do develop mental illness, though, of trauma-exposed youth, depression is actually the most common type of disorder. As a result, PTSD, as you can see below there, is still it's a quarter of youth. And arguably the largest concern is around self-harm and suicide attempts, where trauma greatly increases the risk for both of these, with nearly a quarter of youth having or being involved in self-harm or engaging in self-harm with a history of trauma exposure. Now, add to that the diagnosis of PTSD itself when we come back to suicide. And interestingly, and I think of major concern, is that PTSD carries the highest risk of all mental illness for first suicide attempt in young people. So as adolescents and young adults. So you can imagine if you're combining the impacts of trauma as well as the diagnosis of PTSD, we as clinicians really need to be on the lookout for suicidal thoughts, suicidal behaviors, and doing our best to help our patients mitigate those safety concerns and help with regulating their negative emotions. Okay, we're going to dig in now to some of the epidemiology of PTSD in kids. So here's another question for you all. 50% of all PTSD cases begin by what age? So age 23, which again, when I talk to general audience, is a bit of a surprise. The PTSD is largely thought of as a diagnosis of adults, and not just of adults, but by combat veterans. And in fact, that's how a lot of the diagnostic criteria and a lot of the studies were originally conducted, was in veteran populations and then extending to some other adult populations. But little known is that a large number, half of PTSD cases, really have their onset and their origin in childhood. The other fact here to mention is that, of course, childhood trauma, even if a child or young adult doesn't have PTSD, still increases risk for PTSD into adulthood. So what do we know about the incidence and prevalence of PTSD in kids? Well, the lifetime prevalence is approximately 5% in youth. If you compare that to adults, it's 7%, so actually not strikingly different. However, it matters which population you look at, right? We're just talking about combat veterans, and their rates can go up to 30%. Now, the type of trauma certainly matters as well. And looking at youth specifically, when you look at interpersonal violence, which is arguably the most severe type of trauma that kids tend to experience, now rates go up to 30-40%, which is commensurate with what we'd see in a veteran population. So it can be quite severe. It's worth noting that symptoms can be delayed. There's very little known actually in kids about this, but at least studies in adults suggest that almost half of cases can be delayed by 6 months or more in terms of the emergence or presentation of symptoms. Now, what do we know about the incidence of PTSD over the course of adolescence? Remember, we talked about trauma wasn't evenly distributed over adolescence. Well, PTSD isn't static either, and the diagnosis, like trauma exposure, rises rapidly during adolescence. Here are data from the NIMH website on mental health statistics, it's a really nice resource. And what you can hopefully see here is that the incidence of PTSD is rising markedly. So if you look at age over on the right, it's going from 3.7% age 13 up to 7% by ages 17, 18. You will also likely notice that there are important sex differences here. So females are much more likely to develop PTSD than males. And interestingly, this seems to be the case even within trauma types. So you might think, well, females are more likely to be sexually abused than males, which is true statistically. However, even within sexual abuse victims, females are still more likely to develop PTSD. We think that there may be some genetic, hormonal, and neurobiological vulnerabilities here that, particularly with regard to depression, anxiety, and PTSD, put females at higher risk of developing these particular disorders. So on that note, what are some of the risk factors for PTSD, specifically in youth? We talk about pre-trauma, peri-trauma, so around the time of trauma, and then post-trauma risk factors. So with regards to pre-trauma, we discussed female sex already, but also having a prior internalizing disorder, PTSD. Obviously, trauma load plays a big factor as well, and how repetitive and recurrent were traumas leading up to the episode of PTSD. Some of the peri-trauma characteristics we talked about as well. Interpersonal violence is particularly severe in terms of risk, and being directly exposed. This may seem like common sense, but it does matter whether somebody was directly exposed or not. There is evidence, I will say, even though the DSM doesn't recognize this as a trauma type, that in youth, the amount of media-based exposure can be just as potent as direct or more personal exposures to trauma in terms of increasing risk for PTSD. Acute pain is another important aspect to pay attention to, particularly for kids coming in with injuries, whether it's motor vehicle accidents or abuse-related injuries, that can exacerbate risk as well. And then finally, acute parental stress, and more broadly, caregiver stress. And we often think about kids in isolation, but really as a child psychiatrist, I'm thinking about the family system, and these are family disorders in many ways, because how the parents or caregivers are doing impacts how their children are doing and how they fare in response to trauma. And then finally, post-trauma factors. Intrusive ruminations are really an important indicator, whether it's of the trauma itself, so re-experiencing or reliving, reimagining the trauma, or intrusive ruminations about shame, guilt. There are often constructs that come up with kids feeling like they were somehow responsible, or I should have told somebody sooner. And of course, that makes very little logical sense in those cases because they were the victims. However, these are the types of thoughts and ruminations that come up. And then social support is huge. So a lot of initial responses to trauma really do focus on bolstering social support, like psychological first aid for recovery and skills for psychological recovery, for example. Okay, let's pivot to the diagnosis itself. I'm not going to read all the DSM criteria to you right now. It'll probably put everybody to sleep. But I do just want to give you an overview of some of the main categories of symptoms that we look at for PTSD. We talked about intrusive types of thoughts that can also come out as nightmares, flashbacks, or distress, psychological or physiological, with reminders. Avoidance criteria, altered cognition and mood, and here's where some of those cognitions of blame and guilt tend to come up. And then finally, hyperarousal. Now, what are the highlighted items? Those are the items that are not present in the preschool PTSD diagnosis. And for reasons that kids that young aren't likely to report or be able to exhibit these types of behaviors. And the other notable difference is that there's only one criteria of either avoidance or altered cognition or mood required for preschoolers. Now, interestingly, from a clinical standpoint, why are families coming in, or why might that child be brought in to see us? And it's usually something in the hyperarousal category that's coming to the parents or caregivers' attention, particularly things like insomnia, maybe poor concentration, their academic performance is flagging, or there's irritability, aggression. So those are the kinds of things that are often bringing in families first, and many times not even knowing that there was a trauma that was involved, and that's not uncovered until later. There are some PTSD specifiers, so other subtypes of PTSD. There's a dissociative subtype, and in this case, in addition to the PTSD symptoms we just described, there are also types of dissociative symptoms, either depersonalization or derealization. And this is basically the experience of either oneself or one's environment being unreal or feeling unreal. And finally, we talked about the delayed specification earlier. But let's dig into dissociation a little bit, because again, another theme I want to carry through this talk is that much of what we think we've known about PTSD in kids has been derived from studies from adults. So what do dissociative symptoms actually look like in children or adolescents? And in this case, we don't know a whole lot yet about children, but we do have some more recent studies on adolescents, one of which I'll show you shortly. I think it is helpful first, though, to define what dissociation actually is. And the NCTSN, or National Child Traumatic Stress Network, which is a great resource, I would highly recommend it. They define dissociation as psychological functions that separate from conscious awareness in response to overwhelming trauma. And I really like this definition because I think what it characterizes dissociation as is a potential adaptation of the brain. It's an attempt by the brain, by the mind, to respond to an event that a child should never have had to go through. And when I'm working with patients and families, I think that's really helpful because it's not their fault, and it's something that their brain is really trying to do to help them cope with something that frankly has been overwhelming. I think putting it in that context can be really normalizing and validating for a lot of patients and families. With that said, what does dissociation look like? Is it this in adolescents at least? Is that the same as in adults? Yes and no. The study by Choi et al. In 2017 did find a dissociative and high PTSD symptom group of adolescents. And I should mention, this is a sample from the NCTSN, and they looked at a very broad range of dissociative symptoms that they could potentially consider. And so the authors did find this high or DSM-5 more classical type of dissociative symptoms where there was depersonalization, derealization. Interestingly, those symptoms are actually less common than some of the other dissociative symptoms measured. That group did report, as you might expect, more trauma and maltreatment exposure. However, in addition to that group, the authors found a second subtype of dissociation in adolescents, a dissociative PTSD subtype, what they termed dysphoric arousal. And these adolescents exhibited dissociative amnesia, detachment, as well as numbing. And interestingly, there were fewer classic PTSD symptoms. This group also seemed, or at least was posited to have a higher number of unrecalled traumas that may not have been reported, at least on the instruments that they measured. But this would suggest that there is likely another type of PTSD in adolescence or dissociation in adolescence that's really about suppression and dissociating the conscious thought, memory, and emotional reactions to trauma. And this may be one of the reasons that there could be quote unquote delayed presentations of PTSD, that there may be some adaptive or dissociative suppression of symptoms for a time. So clinically, though, what do we look for in terms of dissociative symptoms in adolescents that we might not be aware of just thinking about adult studies? So adolescents might show daydreaming, they might show amnesia or dissociative avoidance. What does that actually look like? Here's some really nice examples from beaconhouse.org. It didn't hurt, it didn't happen to me, it didn't bother me. So it's as if nothing really happened or nothing significant really happened. That can be a red flag for us as clinicians and certainly for families to be paying attention to. And even though there was a perhaps horrifying trauma or abuse that happened, kids might still be saying this, again, flag that there might be more to the story. Kids might also say, when I go, I'm gone. I like it there. I'm safe. The voices are always there. They do things. They tell me who I can trust. So there may be other mind states in which adolescents are going into. And again, I like these examples because it does, to me, solidify how a lot of these responses really are the attempt of the mind and brain to adapt. So in these examples, kids have created literally a safe space in their minds where they can go. All right, so we're going to pivot now from PTSD to talking about comorbid illnesses. I've got another quiz question for you. Roughly what percentage of youth with PTSD have a comorbid mental illness? So around 70%. And it is the rule, not the exception. So interestingly, the most common comorbid diagnosis with PTSD in kids is ADHD. And in this case, ADHD can be either a precursor, so risk factor for developing PTSD, but vice versa. Trauma exposure PTSD can increase the risk for developing ADHD. And we think that's due to some of the common underlying neural circuitry that really underlies risk for both of these disorders. Anxiety disorders certainly tag along with PTSD and again can also be risk factors. So social phobia, generalized anxiety, mood disorders are common. And then as we get into adolescence, substance use disorders become quite common as well in terms of comorbidity with PTSD. Now, there's another type of trauma-related disorder I want to discuss because a lot of people will ask me, well, what about complex PTSD? Is that a thing in kids and how do we diagnose it? And thus far, complex PTSD is not in the DSM, I mean, either for children or for adults. However, it's not clear whether complex PTSD is really an adequate description of PTSD and trauma-related impacts in children. What is, however, I think a compelling syndrome that's being increasingly recognized is called a developmental trauma disorder. And again, like complex PTSD, this is not in the DSM, but it is gaining increased recognition as well as increased research. This was a disorder originally proposed by Bessel van der Kolk and really surrounds or is aimed at describing types of syndromes that can happen with multiple and repeated chronic types of traumas over the course of childhood. And described as 15 possible symptoms across several domains, but some of the most important ones, including emotion, cognition, relationships, are huge and will come up frequently in terms of what families are concerned with, what kids are concerned with as well. So what are some example symptoms? There might be low self-esteem, a lot of attachment difficulties that tend to be the case, and extreme distrust, even of potential caregivers. Aggression, dissociation is more likely, as well as cognitive difficulties. Treatment is much more challenging with youth who have been through these types of trauma, and there's often significant neglect that's present here as well, and changes in multiple caregivers and households over time is a frequent part of this as well. So in terms of treatment, there's definitely added emphasis on skills around emotion regulation, awareness, self-esteem, and then really focusing on the primary attachment. So if there are safe or multiple safe caregivers involved, really trying to work with them on increasing that. ARC is probably the best known model or treatment modality for doing this, so attachment, self-regulation, and competency, but it's really oriented towards focusing on these particular domains. So we've started talking a little bit about treatment, at least for developmental trauma disorder. What about PTSD more generally speaking? So I've got another brief quiz question coming up for you. What is the most evidence-based therapy for pediatric PTSD? And for those of you not familiar with some of the acronyms here, EMDR is eye movement desensitization and reprocessing. CBT, cognitive behavioral therapy, and then CPT is cognitive processing therapy. So the largest evidence base is for trauma-focused CBT. And just stepping back from that a little bit, trauma-focused psychotherapy is the first-line treatment overall for PTSD in youth. It has reasonable effect sizes, moderate to small effect sizes, depending on the time frame in which you're looking at. And thankfully, it also shows concomitant reductions in depressive and anxiety symptoms. Remember, we talked about how these tend to tag along with PTSD. And so it's nice to see that those symptoms can also be treated by this particular type of therapy. Now, trauma-focused CBT and EMDR have the most evidence so far, and you'll see, those of you familiar with effect sizes, that EMDR actually has a slightly higher effect size than TFCBT. However, the reason we typically recommend TFCBT first, it has a much larger evidence base. It's been used for longer in kids, and as we'll talk about, it has developmental modifications. It was specifically designed for treating PTSD in kids, whereas EMDR is more in its infancy, if you will. It's a therapy that was derived and tested in adults and is only more recently being applied in adolescents. So we'll talk more about that in a little bit. What are the steps of TFCBT? So we use the practice acronym, which I think is a helpful way of remembering many of the different steps. There's a lot of elements that are incorporated into TFCBT, such as the psychoeducation, parent management. There are the more traditional aspects of PTSD or trauma-related therapies, including doing a trauma narrative, exposure to that narrative, and changing cognitions, as well as in vivo exposures. But one of the points I want to make about TFCBT is that this is a family-based therapy, if you will. So typically there's a supportive caregiver that's also involved in doing these steps, these sessions in parallel with their child. And there's also a point at which the therapist is exposing or reading the trauma narrative to the caregiver as well. Again, in parallel. So these are at separate times. And the idea there is to desensitize the caregiver to that child's trauma narrative as well, so that they can be more supportive for their child in live interactions when trauma reminders come up, or actually having the child read the trauma narrative, which is the conjoint parent-child session below. So I think there's some very unique elements to TFCBT, and again, I think comes back to the point that there are developmental modifications here that aren't necessarily in other types of therapy. What about TFCBT for preschoolers? There's less evidence on this. Michael Herringa at Tulane was really one of the primary developers of adapting this for preschoolers. And as you might guess, there's a lot less emphasis on cognition and more on interacting with kids in a way that's accessible for them. So cartoon-based psychoeducation, the trauma narrative and gradual exposure might be conducted through play, through drawing, using imaginary techniques. What is the parent or caregiver doing during this time? So they're actually more present with the child. Physically present in the sessions, I should say, being involved directly in 3 of the sessions, but then watching all of the others as the therapist is working with the child. Now, what about EMDR? How well does that work, and how does it work, for that matter? Well, EMDR is interesting because it focuses heavily on emotion regulation skills. Unlike TFCBT, it doesn't specifically require going through any trauma narrative. And so there's much less emphasis on trauma-related cognitions and having to piece together the entire story of a trauma, which can be very intimidating for individuals, and including kids, to go through, and is one reason why we can have a higher dropout rate. EMDR, on the other hand, really processes more spontaneous beliefs, imagery, body sensations that may be coming up. There's a distraction portion of this too that I think may be helpful for that, and particularly with kids who have been through significant or multiple traumas, or who may have high levels of dissociation, that the distraction piece may be helpful. So this can be visual or auditory, or sometimes sensory as well, with buzzers that are going from one hemisphere, one field, left to right, and so forth. I will just emphasize once more, though, that the evidence is compelling in adolescents. There aren't any really clear studies of the effectiveness of EMDR in pre-adolescents, so I would just take that with a grain of salt. And so far, we don't have any clear developmental modifications for EMDR. How and when, for example, do you involve caregivers? So I want to come back just briefly to dissociation. We talked about how EMDR may be helpful, actually, in some cases where children aren't able to go beyond their dissociative responses and defenses and be able to directly process a trauma. But what about even assessing for dissociation? There are a couple of instruments I mentioned here that are designed and tested in adolescents as well as children. As clinicians, I think it's also important for us to define dissociation broadly and really going beyond the typical adult dissociative criteria of depersonalization and derealization. So be on the lookout, be a detective and suspicious for things like amnesia, avoidance, daydreaming, that can look like boredom even sometimes, but may actually be dissociative responses. And how do we work with kids who have high dissociative symptoms? Well, psychoeducation, validation, remember we talked about that earlier, and really emphasizing in a way how strong and resilient their brains, their minds are trying to be. So that's part of generating that therapeutic alignment. And then grounding exercises are particularly helpful for kids who are high dissociators and make it very reactive, frankly, when we try to begin processing a trauma, whether it's talking or generating other types of memories. So these can be mindfulness-based exercises that literally can be about awareness of the ground, how our feet are touching the floor, the ground, and so forth. Okay, so that's a bit about some of the psychotherapeutic approaches and considerations we might want to bring into mind when working with kids with trauma and PTSD. What about medications? So which medications here are approved to treat pediatric PTSD? Unfortunately, none of the above. There's a lot of work to be done in terms of pharmacotherapy for pediatric PTSD. There are currently no FDA-approved medications. Even SSRIs, which have shown to be effective in adult PTSD and are one of the first-line options for treating PTSD in adults, have shown no benefit, at least no benefit beyond psychotherapy in pediatric PTSD. I will also emphasize benzodiazepines, just like in adult PTSD, should be avoided. There's a temptation, I think, sometimes about wanting to give anti-anxiety agents to children with high anxiety or trauma-related responses. Benzodiazepines, unfortunately, can actually impede learning. So it can impede the psychotherapy process of unlearning trauma responses. There are some case reports that adrenergic blockade could be helpful. These are agents like clonidine or propranolol that might be helpful for reactivity as well as sleep. I've had some success with that in clinical experience as well, but again, we need much more evidence on that front. Now, while there are no FDA-approved medications for pediatric PTSD, there are for some of the comorbid illnesses we talked about. So with depressive and anxiety disorders, it's worth considering SSRIs or SNRIs as needed. Of course, being mindful of the black box warning for suicidality and paying close attention to any emergence of new suicidal symptoms or behaviors. ADHD is an important condition to have adequately treated as well, whether with stimulants, alpha-2 agonists, or other approaches. And I say that because if ADHD is not well controlled, it's really hard for kids to take advantage of these amazing psychotherapeutic approaches that we have. It's simply too difficult for them to pay attention. They may not remember the types of skills that we're picking up. Insomnia is another common condition that comes up, and of course is part of the potential part of the PTSD diagnosis. It can sometimes be helpful to try things like melatonin. Again, I mentioned the alpha-2 agonists, and sometimes antihistamines and trazodone can be useful. Those are all off-label. Okay, that's a bit about treatment. In this last part of the talk, I'd like to get into a bit of the neurobiology of pediatric PTSD. And hopefully, again, by this point, you're getting a sense of how PTSD in kids has unique features. There are developmental nuances in the expression of PTSD and impacts of trauma and how dissociation manifests that we really do need to be considering. And just like the expression and the behavioral profiles in PTSD, I'm also going to show you some evidence here that the neurobiology is different. It matters in terms of the development. So in work that we've been conducting now over a decade now, in terms of using neuroimaging to characterize developmental profiles in youth with PTSD, there's emerging evidence that it really is a neurodevelopmental disorder. And in these different graphs, the blue dots or lines are typically developing youth, so not non-trauma exposed, whereas the red dots and lines are trajectories for youth with PTSD. And what we see, for example, is that kids with PTSD show things like decreased hippocampal volume with age and increased amygdala activation with age. Those are the opposite patterns of what we would expect developmentally speaking. So normally hippocampal volume should increase, amygdala reactivity should decrease as emotion regulation systems come online, like this final graph I'm showing you, where typically connectivity, in this case, functional connectivity between the amygdala and prefrontal cortex would increase as kids age. This is an important regulatory circuit. However, we're seeing the opposite in kids with PTSD. Now, a couple of other points here. It is interesting that there seems to be a very different profile of PTSD when you look in kids, say 14 and under, where they actually have greater hippocampal volume, lower amygdala reactivity, and higher connectivity between the prefrontal cortex and amygdala. So what is going on there? We'll talk a bit more about some possibilities of whether that's an early adaptive response. Is this a dissociative type PTSD that, because of early trauma, seems to present itself? Regardless, it's not until later in adolescence that PTSD in kids begins to look like the adult profile. And that classic adult profile is reduced hippocampal volume, more amygdala reactivity, and less connection between prefrontal cortex and amygdala. Now, Dr. Russell, you heard about him earlier, also looked at white matter integrity with age in kids with PTSD and found some similar profiles. So in these cases, the white matter is increasing with age in the black dots and black lines in typically developing youth, whereas looking at really across the brain, regardless of which white matter tract we looked at, kids with PTSD were showing declining white matter integrity with age. So suggesting that even the connections, these cables that offer a connection between different areas of the brain, are somehow degrading with age or being impacted perhaps by continued stress exposure. So again, what is going on here? There are many possibilities. The short answer is we don't know. There's evidence, I think, for each of these particular possibilities. None of these are mutually exclusive, and nor is this likely to be a complete list. So it's very complicated when we think about neurodevelopment and trauma exposure and PTSD in youth. So I mentioned maybe this is some early stress neuroadaptation. Remember, the pediatric developing brain is very plastic. It has the ability to adapt and respond and learn in ways that could help kids cope with an environment that they're just learning at that time. So perhaps in some ways, these are neural systems that come online earlier or that adapt or strengthen early to deal or cope with a very stressful and potentially traumatic environment. Maybe there are alterations in the maturation in the circuitry. In other words, maybe some of these circuits mature early in kids who are under significant trauma and adversity. But what about these later effects, this seeming decline, if you will, in that neural profile that we see early on? Are these degradation effects of persistent stress and having PTSD itself, which is also very stressful? And then what about the developmental timing of trauma? Does that matter? So I'm going to touch on two of these topics, the developmental timing as well as the maturational pace. So in terms of developmental timing, Marty Teicher's group has some really interesting data. This comes from adults actually, but retrospectively asking about when they were exposed to childhood trauma. And what he's found in his brain imaging studies is that the vulnerability of different areas of the brain is different depending on when traumas happen. So for example, the hippocampus seems to be most sensitive to the effects of childhood trauma exposure between the ages of 3 to 5. Whereas if you look at the amygdala, that's most sensitive around ages 11, 12. And then finally, the prefrontal cortex at the bottom shows highest sensitivity ages 14 and onward, which makes a lot of sense. The prefrontal cortex is the last area of the brain to fully develop. In fact, it's developing through the age of 25. And so not surprisingly, it would be particularly sensitive to the impacts of trauma around those ages. Now, Marty's group also looked at amygdala reactivity. And interestingly, what he found here is that prepubertal stress was associated with decreased amygdala reactivity or blunting, whereas postpubertal stress was associated with increased amygdala reactivity. And remember, this actually mirrors some of the findings that I showed you in our longitudinal cross-sectional sample of amygdala activation in kids with PTSD. So what about stress-induced changes in brain maturation? This is a relatively new area of research that neuroscientists, we and others have been looking at. And it takes some complex mathematical modeling, but what we're trying to do is estimate the brain age, whether it's structural brain age, functional brain age, compared to typically developing youth of the same age, and trying to get an assessment of whether there are stress-induced acceleration of maturity in certain brain areas, or even deceleration, where certain brain areas may be less mature. And we started by looking at a fairly large cohort of female youth who had been victims of abuse, others typically developing. So this was work led by Dr. Taylor Kading and published in 2021 now, where he looked at structural brain age and looked at several different circuits. So first he looked at whole brain. This is on the far left. He also looked at language circuitry on the far right, and he found no differences between typically developing females in blue compared to either trauma-exposed, resilient, or susceptible females in red or purple. However, when he looked at emotion circuitry in the brain specifically, that showed delayed maturity in both trauma, resilient, and susceptible females. So suggesting that there might be some broader or general effects of trauma exposure that are actually delaying brain maturation in emotion circuitry, both responsible for emotion processing as well as regulation. But the story thickened from there. So the way that their brains matured showed very different patterns between resilient and vulnerable female youth. So in resilient female youth, which I'm showing you examples here, there was actually a pattern of increased maturation in the executive network. So this allows us to control and regulate emotions, to regulate our attention and working memory. So these areas actually showed increased maturation as contributing to the overall pattern, while there was decreased maturation in the salience network. What's the salience network? Well, it's a brain network that's responsible for detecting anything that's potentially important for our survival, our well-being, and our thriving in the environment around us. Now, that can be both threat or potential rewards. When we think about trauma, it's often in terms of threat detection, and so the salience network is heavily involved with that. So it could be that in resilient female youth, for example, there's a broader or more generalized threat detection circuit going on that might underlie hypervigilance, but complemented by greater executive network maturity that allows the brain to differentiate then what's important, what do we pay attention to, and what not. On the other hand, vulnerable female youth really showed the opposite pattern. So in their executive network, they showed decreased maturation, particularly in the hippocampus, which is important for contextualizing our emotional responses and when we consider something a threat or not. Whereas there was increased maturity in the salience network, which could be, again, indicative in this case of greater reactivity, particularly to specific stimuli. So there's a lot to be learned about brain maturation in neurobiology, in pediatric PTSD, and what's responsible for these differential profiles, depending on what age that we look at. What do we know, however, about remission from PTSD in terms of the brain, and what does that look like in youth? Well, this, I think, is an area that can give us some hope, and something certainly to tell patients and families as well, is that the brain itself seems to recover when PTSD is recovered. And what Dr. Haynes showed, who looked at a longitudinal study in our sample of youth with PTSD, is that structurally, the brain actually expands. So in youth who've remitted from PTSD, shown in yellow in the graphs, they show a literal expansion of the prefrontal cortex, in this case, both the frontal pole and ventromedial prefrontal cortex in youth who recover or remit, in this case, from PTSD. That was further associated with lower anxiety symptoms over time. And this we found really interesting because that's an important regulatory area of the amygdala and more broadly the salience network. Now, Amy Garrett and colleagues also conducted a study with brain imaging in adolescents going through trauma-focused CBT and found some similar findings. So when she looked from post to pre-TFCBT, she found that adolescents showed expansion of the prefrontal cortex once again. So here in the dorsolateral and ventrolateral areas of the prefrontal cortex. So this would suggest that we can, in fact, harness the neuroplasticity of the developing brain. And while it may be more sensitive in many ways to trauma exposure, it can also be more sensitive to the potential restorative or resilience building effects of psychotherapy and other approaches that we might harness. So this, I think, comes back to a theme of what really got me interested in child and family psychiatry, is that we do have the potential to harness the plasticity of the developing brain to do many good things and hopefully allow kids to not just survive, but thrive as they enter adolescence and young adulthood. All right, so for those of you who have nodded off by this point, here are some of the takeaway messages from the talk. Trauma and PTSD symptoms change over the course of development. Again, this is not just a little version of PTSD from adults. From a treatment standpoint, trauma-focused psychotherapy is effective. It's a first-line treatment for pediatric PTSD. And unfortunately, we don't have any evidence-based pharmacotherapies for pediatric PTSD, although again, treating comorbid conditions can still be very helpful. Pediatric PTSD appears to be a neurodevelopmental disorder, and that, I think, we can make a good case for that at this point, both from the neurobiology, but also from symptom-related differences in expression of trauma across childhood and adolescence. And then finally, recovery from PTSD in youth may involve some restoration and rebuilding of executive function circuits and some tempering of threat response or salient circuitry. Now, I want to talk or end just a little bit about some of the new types of interventions that we're trying. And it's one thing to study the neurobiology and symptom presentations in youth with trauma and PTSD, but ultimately, we want to be able to use these types of findings, these types of data, to develop new treatments and new interventions that can be much more effective for youth and really are tailored on the neurobiological profiles and where youth are in development. It's also important in working with kids and adolescents that we make these kinds of interventions more accessible and ideally even fun, at least as fun as you could possibly make a treatment that's trying to help with trauma responses. And so I want to give you an example of one of the projects we've had the great fortune to work on, and this is developing a virtual reality breathing-based biofeedback to help teens better regulate their physiology, to help better regulate their emotional responses. And this is an incredible collaboration amongst our group, but working with Explore Deep, as well as other collaborators. These are software designers, virtual reality experts, game designers, as well as game theoretical experts as well, and understanding how games can be optimized for youth as they're developing. So I want to show you an example of a video clip showing how this particular intervention works. It's built in an underwater environment and uses breathing directly to facilitate how kids move through the underwater environment. And what it encourages, the biofeedback encourages, is a deeper, more regular style of breathing that we call diaphragmatic breathing. Many of you are familiar with that, I'm sure. But that's thought and known, more than thought, that's known to promote parasympathetic or soothing, calming types of physiological responses. And we think doing that in this type of virtual environment can then help kids as they go out in the real world and have to manage their physiology and be more aware of it as they go along. So here's a video clip to hopefully give you an example of what this is like. So we've been able to start piloting this VR biofeedback in youth in the juvenile detention center here in the Dane County, Wisconsin area. And that, as you might anticipate, is a tough crowd, but they've really enjoyed this particular game and intervention so far. They show improvements in their physiology as well as their self-reported emotion regulation. They show improvements in their anxiety and depressive and PTSD symptoms that increases with the number of sessions of virtual reality that they do. So early data is very promising on this for its ability to help kids, but we'll certainly need to do more research, including fully controlled trials as well. So lastly, I'm going to leave you just with a few resources. I think you heard me mention a couple of these, at least Child Trends and the National Child Traumatic Stress Network. It's also, I think, for those of you not practiced or trained in TFCBT, there's a really nice entry point into learning this that's called TFCBT Web. It's run by the Medical University of South Carolina. I would highly recommend that. Just note that the overall certification for TFCBT does also require more than the web-based program, actual case overview and supervision by trained supervisors. So thank you all so much for your attention. I'm going to end here, and then we can pivot, hopefully do some question and answer and broader discussion with the audience. So thank you, everybody.
Thank you so much, Dr. Herringa, for your thoughtful and informative lecture. It's been such a pleasure speaking with you today. We're going to get started now on the Q&A portion of the grand rounds. I see there are already a number of questions in the Q&A box, but for those of you who haven't yet, you can please start inputting additional questions now. And I will get started with some of the questions that have been in the box already. So the first question here was related to one of the early slides about the higher prevalence of trauma in Black and Hispanic youth. And the question was whether this data controlled for socioeconomic status, and if so, did the racial component, quote unquote, wash out?
Yeah, I think that's a really important point because socioeconomic status is also associated with greater incidence or likelihood of trauma exposure. I don't know if they controlled for it in that particular Child Trends analysis. I believe they did, and that there are unique effects of both racial or ethnic background as well as socioeconomic status. And certainly other data would bear that out too, particularly when one looks in areas of racial discrimination, for example, that's not merely a function of socioeconomic status.
Absolutely. Thank you so much.
Yeah.
One other question is, so I know you mentioned the importance of family involvement in trauma-focused CBT, which of course makes sense. I was wondering if this treatment can still be done with a child in an instance where there's not a supportive caregiver available. For instance, if the parent or caregiver is reluctant or unwilling, in this case, would you think about another treatment, or is there still a modification of this treatment that would be workable?
Yeah, that's a great question. Thank you for that. You can do trauma-focused CBT without a caregiver involved, and the data show that that still works reasonably well, at least for adolescents. I think there's less data on that in younger kids and whether and how appropriate that is. Sometimes we will try to find rather an alternative caregiver or support, an adult who might come in to be helpful with that child, and maybe it's not a direct caregiver even, but another family member, a grandparent, a coach, or someone else who's been involved in that child's life. But with that said, TFCBT can still be effective for the child alone, and in that case, the therapists themselves, we kind of become the caregiver support, if you will, through that process.
Yeah, that makes perfect sense. Thank you so much.
Yeah.
Okay, let me just sift through a little bit here. Okay, somebody says, I work with kids on Medicaid in New York City. It's quite difficult to find providers who do trauma work who aren't private providers. Any thoughts or hypotheses about whether deep VR will be available to kids outpatient in less resourced communities? I know you can't tell the future, but just any thoughts on kind of where this might go?
Yeah, well, I appreciate that clinician also bringing up the issue of access, because I think that's a major problem in terms of really getting the treatment that kids need. Is frankly, one, being able to access a trained therapist, but two, a trained therapist they can afford or actually takes their insurance, that lives near enough to be able to see them. So you're right, we do need treatments, or at least ways to augment treatment that can be scaled, hopefully. And that is our hope for deep VR, for example, is that we can really develop this in a way, hopefully within the next couple of years, that would be able to be done at scale, that not all, but the family would need to get access to a VR system, but maybe that's something that could be embedded, for example, in a school or a community center where they don't even have to purchase that themselves. So that is our hope, to be able to scale treatments like this more widely. We're also thinking about ways to better intervene or even have preventive programming earlier in schools so that we're reaching as many kids as possible, that hopefully mitigate some of the impacts of trauma and PTSD in kids.
Absolutely. Thank you so much. And thank you for showing that demonstration too. It was really cool to see kind of what that looks like, and what that experience might be like for someone doing that treatment. Many parents, this is just another question, many parents may not connect their child's behavior with trauma. Do you have any ideas or suggestions or even sound bites on how to help them make the connection between potential behavioral issues that are experiencing and trauma?
Yeah. Oh, this is such a sharp audience. My gosh. Can tell there's some very astute clinicians here. That I think can be a really tricky point, but it's a really important one, because parents may often come in, or caregivers generally, looking at their children as behaving badly. And this is interesting too, because males and then males of color will particularly often get labeled that way when they're coming in with behaviors that are not conforming. And what the child may actually be doing is acting out or exhibiting the symptoms of trauma. And so what I try to do with families, with caregivers in those situations, is to help them understand, to take a trauma-informed lens and think about, well, what if this is actually a trauma response? And it's not just your child being disobedient and not obeying what the house rules are or whatever it is, that they're actually just doing their best to try to cope with really scary and difficult events that and sometimes, in many cases, the caregivers haven't even known about. So that's sort of the paradigm shift, or shifting of the lenses, that I try to help families with who just may not be aware, one, that there were even traumatic events that happened, but then two, if they do know about that, well, how might we re-envision these behaviors as doing their best to try to cope with trauma? And another example of that might be, well, the child actually gets attention from their caregivers if they are acting out. And maybe it's just that they're so afraid of being away from their caregivers that something either bad could happen to them or their caregivers, that all they know how to do is act out so that I get more attention and I'm going to be near my caregivers, so I don't have to worry about either of us being injured again.
Absolutely. There are several questions kind of on differential diagnosis, so I'll try to pick a couple. But one is, you may have discussed this, but is there more information or thoughts on the correlation with PTSD in youth and the diagnosis of dissociative identity disorder? Excuse me.
Great question. I have not seen much data on dissociative identity disorder in youth, and more so in adolescents. I think there's even less data in younger children. So I don't know that I can answer that well. I think that's just an area where we really need more data. The NCTSN sample is probably the best we have right now to really be able to look at that, because it's a nationwide sample, I believe, of some 1,500 youth with PTSD, but that I think could potentially look at those types of questions. But I don't believe anybody specifically looked at diagnosis of DID in that particular sample. So there's definitely a lot more to be learned there, and including how DID might emerge over the course of development. So maybe it actually is there earlier in adolescence. We just don't know particularly what that looks like yet. And I think that comes back to some of the slides I talked about in terms of, well, what does dissociation even look like in adolescence? Turns out it looks quite a bit different from adults. And so I don't think that has not yet been integrated into the diagnosis of DID.
That absolutely makes sense. One other question, can you speak about the role of neglect in childhood trauma, i.e. negative trauma, which should be there but is absent?
Yeah, yeah. Another really astute question. So the neglect piece really, I think, takes or imparts a double hit, if you will, on children growing up. So it is a really difficult situation for the child themselves because they're losing some of that scaffolding for emotional support, for well-being. There's evidence actually that neglect itself may change brain development, but in ways, interestingly, that might accelerate some neurodevelopment because kids are needing to really take on a caregiver role for themselves earlier than they should have to. The other side of this, though, is that with neglect, the social supports and buffers against trauma are also removed. And so now when kids are experiencing trauma, the impacts tend to be more severe because there isn't that caregiver buffer or buffer of the family system or other support systems. And then we didn't get into the attachment related processes deeply, but that's another really important aspect of this, that if the neglect is very severe or happens across multiple households or caregivers, that's when it can be quite much more likely to be entering into developmental trauma disorder, where there are a lot more attachment difficulties. And this really is a vicious circle because with attachment difficulties, now kids also tend to have more challenges in creating friendships or bringing on other trusted adults as they go on, whether it's a teacher or a guidance counselor or even a therapist for that matter. And so they're both unable to harness or gather social supports, and then they are still very vulnerable and prone to being re-traumatized and having a large negative impact from that.
Yeah, absolutely. And I feel like you kind of touched on this in what you were just speaking about, but I guess maybe along those lines, what do we know either from research or anecdotally in your practice about some of the protective factors that can mitigate the impact of trauma and perhaps even the emergency of sort of full-blown PTSD following a traumatic event, whether that's caregiver support, other support? I know you kind of spoke on some of those topics, but.
Yeah, I think the family system really is critical. So with a supportive family system, bringing them into the fold and really bringing in all the family supports possible, and also educating that family on what that support looks like. That doesn't mean, by the way, just asking your child over and over about what happened and reliving the trauma and watching the news about something again and again. You know, it's really being mindful of, okay, how much exposure do we actually need? And that should be focused around keeping the family system and that child safe to try to prevent something bad from happening yet again. So there's enough just to really focus on security and safety, but much more of the emphasis should be on other types of coping skills. What do we need to do for self-care, for example, and what kinds of safety plans do we need to put into place that it's never a guarantee, but can hopefully assure that child that we're doing our best to keep you safe and keep you okay. So those are the kinds of skills that are built into psychological first aid and skills for psychological recovery. If you look at the NCTSN website, that I think are really helpful. And then the psychoeducation piece is another part of that. That oftentimes, well, there's a risk anyway, that kids can come out of a trauma, families for that matter, saying, oh my gosh, what is wrong with me, or why me? And this has never happened to anybody else, or it might feel like that, right? So some of the psychoeducation is just about normalizing, unfortunately, just how common trauma is, how many kids are exposed to that, and how many parents and caregivers and families have to deal with that too, and that there are ways to recover and be resilient to that. And it's also okay to feel what kids are feeling.
Thank you so much. Okay, this is a bit of a longer question, so bear with me. Okay, so first they start by saying, thanking you so much for all your thoughts and very rich information, fascinating. I've observed a gap when it comes to clients that have been referred to me. I work with newly arrived Spanish-speaking students, elementary to high school. Often the referrals include knowledge of the child's story and potentially traumatic events. for instance, loss of family while crossing the border, exposure to community violence in the home country, abuse and domestic violence in the US. The gap is that often, even when students acknowledge the fact of these potentially traumatic events, they have almost always either not wanted to talk, saying stuff like, I don't want to talk about it, it's too painful, or this individual hasn't detected problematic symptoms in the client, either by observation or parent report, i.e. they seem to be functioning pretty well despite the fact of the potentially traumatic events. So this person's wondering if you can speak a little bit to that gap, what might be happening, what steps would you potentially recommend for treatment?
Yeah. Yeah, those sounds like some challenging cases for sure. I think in the latter case, it would be worth probing a bit more for dissociative symptoms, and some of the scales I put up would be worth seeing if your clients would be willing or interested in completing. The exposure piece, I think, is a really challenging one. It's challenging in all trauma work, but somehow it's more challenging in kids because when they don't want to go somewhere, they won't, right? They won't talk about something, and there's nobody who's going to make them do that. So I think the best thing we can do as therapists in those situations is to validate that, to say, really in a psychoeducation approach, that's understandable that you don't want to talk about that. That's really horrible. And doing some of the psychoeducation, I typically use an analogy, something like a wound or having a splinter. A lot of kids have experienced splinters at some point, that if you just leave that splinter in there, it's going to get infected, it's going to fester, and it's actually going to hurt more and more as you go along because it's getting infected. And so what we're trying to do in trauma therapy is actually remove that splinter, but it might hurt a little bit more while we're doing it. So sometimes analogies can help. On the other hand, it's also trying to meet kids where they're at. And this is the delicate balance, I think, of trauma work is, okay, well, what would you like help with? What do you think I could help you with? Because obviously I can't force you. I'm not going to force you to talk about your trauma. And seeing if is there another way? Is there another pathway? And to continue to build that therapeutic rapport, even if they don't want to talk about the horrible things that have happened to them. Of course they don't. Who does? But if there is a way, I think, to continue building that rapport, that can be really helpful. And then gently, you can get into nudging more and more as that trust is built about talking about these more sensitive events that may be getting closer to trauma. I will also mention EMDR again, at least for adolescents, that can be another helpful avenue in that I think is a little bit less intimidating than, okay, tell me all the horrible things that happened to you and we're going to write it down.
Thank you so much. I love the splinter analogy, and also the idea of kind of trying to find another angle in, or almost like another motivational hook, like let's start here and then we can get to the other stuff.
Yeah.
If and when we do. A couple of different medication questions. One of them is, can you comment on the use of prazosin to decrease hyperarousal? I think there are a few different prazosin questions.
Oh, sure. Yeah. I thought that might come up because there's at least some evidence, albeit mixed, that it's helpful for adult PTSD. The more recent larger studies were a bit disappointing, at least in combat veterans on that account. There are mixed findings in pediatric PTSD. Prazosin might be helpful. It might not. And so it's hard to say anything conclusive about that. There have not been any randomized controlled trials in pediatric PTSD. So that's first and foremost what we need to do. I will say, at least in my clinical experience, kids have not tended to tolerate prazosin all that well. They get either headaches, sleepy, blood pressure issues, whereas they do seem to do a little bit better. Again, this is only my clinical experience on clonidine, guanfacine, which interestingly are also having the same effect of reducing sympathetic nervous system arousal. However, they're doing it as an alpha-2 agonist. The nice thing is that both of those medications are approved for use in kids for other reasons, for ADHD primarily. So I tend to really lean towards using those instead of prazosin, but occasionally, and my colleagues have had some occasional benefit with using prazosin as well, particularly in older kids.
And then there are also a number of questions about kind of, it sounds like to me like complementary or additional therapies. So questions about benefits of music therapy, drama therapy, equine therapy for pediatric PTSD, and then a comment, don't forget about play therapy, which has been around for over 100 years. So any thoughts on kind of any of these additional modalities that we might use in the treatment of pediatric PTSD as well?
Yeah, I love that. Yes, and thank you to whoever put in the comment about play therapy. You're absolutely right, and I tried to hint at that as one of the modalities that's actually integrated, particularly for preschool PTSD. But you're absolutely right, and play therapy is great, especially for younger kids. And I think that's something that we shouldn't forget. And I think maybe the broader theme here is, as therapists, being creative. This is really about finding what works for our patients and our clients. If it's equine therapy, great. If it's play therapy, wonderful. So it's really finding both the therapeutic rapport, but then also a particular modality that's going to be helpful for our patients, because I think that each child and family is unique, and ideally we'd meet them uniquely with their needs and finding what type of therapy would work best. At least with music, equine therapy, I do have to acknowledge the evidence base isn't there, but I would still personally encourage folks to use that when needed, and you can see with your individual client whether something is working or not.
Thank you so much. One additional question. I have heard arguments that ADHD is not really that high, that it is the symptoms of PTSD that make rates of ADHD look high. Any thoughts or comments on that?
It's an excellent point, and it can be difficult to tease out, frankly, because ADHD can make PTSD look worse and vice versa. So they're not mutually exclusive. There are situations, though, where PTSD mimics ADHD, and particularly when that's compounded with significant sleep disruption and insomnia. Because when we aren't sleeping well, our brains basically are looking like they're ADHD, right? We don't have that attentional capacity and working memory and so forth. So that diagnostically can be really tricky, especially when seeing a child for the first time. Usually we can begin to tease that out over time, so that as, say, trauma symptoms are being treated, maybe sleep is improved, if all of a sudden the quote unquote ADHD goes away, well, then we know pretty likely that was due to PTSD related or trauma related symptoms. If it's still there, however, that might suggest, well, both diagnoses were there from the start, and we need to be thinking about both. So it's an ongoing evaluation process, and I wish we had better diagnostic tools to actually figure that out. That's some of my hope for brain imaging and other types of work that we're doing.
Okay. Okay, wait, we have time for maybe one or two more questions. We'll see where this one gets us to time-wise. So how would you explain someone's experience of childhood trauma that is, quote, repressed until adulthood, where the adult started experiencing PTSD symptoms related to these specific childhood experiences during their late 20s rather than throughout their childhood and adolescence? And then could this be related to the development of the prefrontal cortex, or any thoughts about this sort of big topic, but thoughts on this?
Yeah, I think how I would try to explain that to one of my patients, and I have done this before, is that your brain did an amazing job of really coping and suppressing a memory that was simply too overwhelming and traumatic to deal with as a child. And it's only now that it might be coming out for various reasons. Maybe it was triggered. Maybe there are other reminders or other traumas that have come up since then. And then from the neurodevelopmental standpoint that we talked about, I think there likely are some very different brain development responses to early versus later trauma, even in childhood. So those very early traumas, I think, are altering the neurodevelopmental course of the brain in a way that it likely is suppressing, or more likely to suppress, some of those memories. Because what does the child brain really know what to do with those kinds of memories at that point? So I wonder, I'm speculating now, but that actually is some adaptive suppression, so that that child can hopefully continue to do some of the things at least a child should be doing, like attaching to safe caregivers or making friends and so forth.
Yeah, absolutely. One more question. What are your thoughts about teachers being more aware and able to help identify and work with these ideas?
Yeah, teachers are amazing, and I think to the extent that we can involve them, I think this can be really helpful. And in fact, one of the modalities that we're trying to pilot right now with one of our school partners in Dane County here is using self-compassion, but it's a trauma-informed compassion-based programming and mindfulness-based programming that hopefully teachers can begin to pick up too, and that infuses the classroom. But I think that I love this comment because just like the families we talked about earlier, it's also important for teachers to be able to take a trauma lens and think about, oh, why isn't my student care even about their grades or this particular topic or course that we're working on? Why are they acting out in class? Is there something else going on? And rather than them simply labeling them as disobedient, again, maybe there's something else going on, and maybe trauma is part of that. So I think having that same lens can be really helpful in the schools.
Yeah, thank you so much. Okay, last question. Thank you so much and there have been so many questions. I can tell people are really excited and interested on this topic, and there's so much we all want to know more about. So the last question is, how do you differentiate between internal chatter / voices related to PTSD and psychosis in adolescents?
Mm-hmm. Another excellent question that let's see how I can give a short answer to this, because I know we're running low on time. Typically, there is more of a trauma link, if you will. If voices or hallucinations are trauma and or PTSD related, it's typically something around the content of the trauma or around threat or around keeping oneself safe. And so I think that's an important lens. There's also very often an acknowledgement from the youth standpoint, at least for adolescents, about what those voices are doing. Do they seem to be in response to trauma? Does it sound like, in the case of more intrusive voices, is that actually the voice of my abuser that I'm hearing? So oftentimes there are clues where you can identify, oh, that's a pretty clear link to the trauma and or the PTSD. Whereas for psychotic disorders, those I would say are often more intrusive or in the sense that they're not specifically related to a traumatic event or any of the thematic content there. There might not be any clear link to a perpetrator, for example. And then, of course, we're looking at the whole picture, or trying to look at the whole picture. So are there other suggestions or symptoms of psychosis that perhaps this has been more gradually onsetting, actually, in retrospect, over the past couple of years? Maybe there's more negative symptomatology going on, social isolation, reductions in affect. We're kind of looking for other potential symptoms of the syndrome that might help differentiate one or the other. But I will end just on that note saying that what is the most common cause of hallucinations in kids and adolescents? Well, it turns out it's anxiety, and PTSD is really a form of anxiety. It's threat-related anxiety specifically, but I think that's something for us to keep in mind as clinicians as well.
Thank you so much for answering such a complex and nuanced question in such a basic way, and for your entire presentation today. And thank you to everyone for joining us. As a reminder, for those wishing to receive continuing education credits, please complete the evaluation survey that will automatically show up in the browser as we end. We hope you can join us again on April 23rd, but for now, that concludes today's Grand Rounds. Thank you so much, and goodbye.